oxygenated. We couldn't even do that routinely until the mid to late 70s. Pediatric surgeons became more broadly available. There were more neonatologists. Extracorporeal membrane oxygenation, or ECMO, was first described, and I'll talk about that. And there was a recognition that high pressures in the lung, or pulmonary hypertension, were really an important problem in these babies. So the more pediatric surgeons were important, so you can have people who are comfortable operating on infants at a younger and younger age. And Henry Michelini looked at the data from Lally in the late 70s, and if you look at this time shift, and what occurred is that they're operating on more children less than 72 hours of age. So about the role of ECMO. The first newborn was put on ECMO in 1974. That was an infant in UC Irvine. And in 1977 was the first report of use of ECMO with diaphragmatic hernia. And that was a case series of 3 patients that they described with 2 survivors. Because extracorporeal membrane oxygenation is a rescue strategy for babies with respiratory failure who are dying, it became inexorably linked with diaphragmatic hernia. So there was an interest in doing that. I don't know if any of you had one of your kids on ECMO. Would be actually that's the Arkansas Children's setup. And this is one of the first kids we did. But if we look carefully at what kind of babies were being put on ECMO in the 70s, they were several days of age, 3, 4, 5, 6 days of age. Most of the patients had ventilator-associated lung injury. It was a mechanical ventilator generating high pressures into the lungs that were beating up the baby's lungs, and that was the cause of their problem. And they didn't have any other anomalies. These are babies with isolated hernias who had the ventilator that caused their lung injury, and that's when they went on ECMO. By the 80s now, we started to move further into different management strategies, and hyperventilation is a very important and a very interesting phase of management of these babies, which we've moved away from. This is from an article that was published in 1981. So at that time, early 80s, the view is we are making no headway in diaphragmatic hernia. These babies are just sick, and we've got to do something different. And what this article shows is known physiology, that as you drop the carbon dioxide level lower and lower, your blood gas goes up, your oxygenation goes up. And the reason is because it causes the pulmonary vessels to relax. We increase blood flow to the lungs. And so people looked at that, and then you looked at, similarly, the blood, as you got the baby more and more alkalotic, the oxygen levels got greater. That was from 6 patients. But on the basis of those data, when people are sitting at the bedside of an infant who is blue, they're going to want to try and make the baby pink. And so in order to do that, you have to increase the ventilator. You have to turn up the pressure, and you have to turn up the rate. And you can do that. You can make the baby temporarily pink. The problem is there's a cost to that. And the cost is lung injury. So as we increase ventilation with a mechanical ventilator, that's a life-saving device, but it'll also can kill people. And as you increase pressures, you will increase lung injury. So what would happen is the baby would turn pink, and then 24 to 48 hours later, they'd be turning blue again because their lungs were now seriously injured. And that led to what we call the, quote, honeymoon period that used to exist in diaphragmatic hernia. We don't see it anymore. It was a transient phase when we had mechanical ventilator-induced lung injury based on a strategy for ventilation that ultimately didn't make sense. But most people in this field are very goal-directed, so if you tell them you've got to hit this kind of target, we're going to try very hard to hit it. The other thing that was occurring in the 80s, remember we had this emergency deal, surgery, diaphragmatic hernia. This is actually from one of the major textbooks of surgery in 1989. And when this came out in 1989, I was already out of my training. I was 2 years into being a pediatric surgeon. And diaphragmatic hernia is acknowledged to be the most urgent surgical emergency in the newborn. And a point of fact, during my training from 85 to 87 in Los Angeles, we had an infant that was helicoptered into the hospital, and we went from the helipad to the operating room. We felt that it was that level of an emergency operation. Problem was the basic concept behind it. This goes back to Dr. Gross. My surgeon-in-chief trained under Dr. Gross. It was an emergency. We got to fix the problem. The thought was that it was the valve up in the chest causing the heart to shift, and that's why the baby was having problems. And in point of fact, that is the patient that they were taking care of in the 50s. That was the 3 or 4 day old baby who had a lot of gas in the chest. Their lungs were actually okay, and it was the increasing air and pushing everything over in the chest, and there was an emergency to take care of that baby. That wasn't the babies we were seeing by now. These infants were a whole different set of problems. It came a series of reports. The first one was Sakai and colleagues in sick kids in Toronto, followed by the folks in Netherlands, Frans Huysbroek, and then a sequence of other papers in the early 90s. And all of them suggested that taking a period of time to stabilize the baby before you got to the operating room was a good idea. In point of fact, what all these studies showed was no worse outcome. They didn't actually show dramatic improvement, but no worse outcome. And that led to a shift in philosophy about management of these babies to where we delayed surgery. And if you look at, these are data from our registry, but if you look now, these are current data, the number of times where people are going to get surgery between midnight and 6 o'clock in the morning is very, very infrequent today. This bar graph would have been much different if we had data from the mid-80s. Because when I was in training, if we had a baby at 2 o'clock in the morning, we'd go right to the operating room with diaphragmatic hernia. That is not the case at all today. Today we will delay these pieces for lengthy periods of time. Segue to the 90s now, and we began to have increasing advances in neonatal critical care. There were 3 things that became available between 1988 and 1993 that had dramatic impact on neonatal respiratory care, less dramatic impact on management of diaphragmatic hernia. That was availability of nitric oxide and inhaled pulmonary vasodilator, surfactant in babies who had inadequate lung surfactant, and the high-frequency oscillator. All of those became available around that time period. But if we look at a few, advances in neonatal care, pulse oximeters became available in the 90s, a huge device. We can now manage the baby's, trend the baby's oxygenation without having to go with blood gases. We had microsamples for these babies. Before this, these microanalyzers, you had to take 2 or 3 cc's of blood just to get some simple data every time you went to lab. Pediatric anesthesia became a defined specialty, and we began to have more availability of defined specialties, and ventilators improved dramatically. Frankly, they continue to improve even today with microprocessing. We started to look at what we were doing. This is the group in New York, starting in the mid-1980s, started to publish a small series of patients where they did not hyperventilate. In fact, suggested that hyperventilation was a very bad idea. David Case is a pediatric surgeon in Florida who trained in New York. And David came down to Florida, where that original case report was of those 6 patients. It was the University of Florida. And David came in there and started applying what they did in New York to the patients in Gainesville. And this is what he demonstrated. Era 1 is the era of hyperventilation. This is a transitional era, and then this is the era when they started to do what we would call minimal ventilation, or low pressure, so we're not beating up the lungs. While there was previous papers about it, some articles are just more important to know that this was in a journal more widely read, so it really began to get traction in the early to mid-90s about the thought that some of the mortality that we were seeing from diaphragmatic hernia was physician-induced. We were killing the lungs. And so there have been dramatic shifts in management